Our next talk is High Flow Nasal Oxygenation by Dr. Karunakaran Ramaswamy, who's a consultant anesthesiologist at Northampton General Hospital, United Kingdom. Over to you, sir.
Thank you. Happy afternoon to you all. No conflicts of interest. When Apple decided to enter into mobile market, one of the first questions Steve Jobs asked his R&D team was, do we need these buttons? Before anyone could answer, he said, we need to get rid of them. How you do it, I don't care, we need to get rid of them. Considering that's how we would communicate with a mobile device, this was a big ask. And they worked hard, they came up with iPhone. This has revolutionized the way mobile phones are designed today. And it's credit to the team to think about this. This is our Archie brain. We have gone through him thrice today. And this device has revolutionized the way we think about airway management and the way we deal with airways. Today, we are at the cusp of another great airway revolution. And before we delve into that, just going to take a step back, explain to you what the kit is, because many of you may not have used it. And we'll go to just 2 or 3 studies looking into that, and then we'll see how it might revolutionize the airway in future. This is the high-flow nasal oxygen delivery device. Our colleagues in intensive care have been using it for about a decade. They know about it, but I'll just quickly explain for the audience. You got an oxygen and an air port. That's the FiO2 knob, and you can control your FiO2 between 21% to 100%. Then we have a flow meter, and this is the unique bit of the kit because it can deliver up to 70 liters, 70. And this high flow is extremely important because when we take a breath, we need the peak inspiratory pressure. And if the flow meter cannot deliver the flow, we take room air from outside and your FiO2 will go down. So this high flow is the key for delivering in this device. At this rate of flow rate, our body will struggle to heat and humidify the air. So we need a heating and a humidification, and it's delivered via nasal cannula. So it's a very simple device to use. You set the flow rate, ensure it's heated and humidified, and off you go. So let's go back to this thrice study. I'm just going to spend some time because this is an important hallmark study. So this is an observational study looking at 25 patients with difficult airway. 12 of them were obese, 9 of them had stridor. So fairly difficult patients for intubation. They had a fairly prescriptive technique. So they would have all the patients pre-oxygenated with 70 liters of oxygen. They would induce the patients with propofol, fentanyl, and rocuronium. They would do a basic jaw thrust maneuver to ensure the airway remained patent, and they would keep the patients asleep using total intravenous anesthesia. The airway management was 3 types. So most of these patients, because they were having laryngotracheal surgery, would have a suspension laryngoscope with jet ventilation. Few patients had endotracheal intubation. Again, the technique was very prescriptive. They would use a Macintosh laryngoscope first attempt. Second attempt would be with the AP, normal video laryngoscope. The third attempt would be with the AP, advanced video laryngoscope. And their primary endpoint, that is the endpoint of the study, would be apnea time. So what is apnea time? It is the time from which the muscle relaxant is administered to the time when one of these airway devices is secured. Just want you to think in your own anesthetic practice. So how long does it take for a patient to desaturate once you are given a muscle relaxant? Just close your eyes and just have a moment and think about it. And the secondary endpoint was, what was the carbon dioxide level at the end of the apnea time? So this is the graph summarizing the primary endpoint, which is apnea time. So you got apnea time in minutes in x-axis, and you have the oxygen saturation in y-axis. Just going to describe this graph with 3 sections. So first section is the patients on the top. The second section is the patients there. And third is patients towards the right end. So let's talk about this first. So these are patients with normal BMI. And they took about 15 to 20 minutes. You will see why they took so long to secure an airway. But they remained fairly well saturated. They had normal BMI. They remained fairly well saturated at that point. These are patients who are obese, and 3 of them were morbidly obese. And you see that they started desaturating fairly quickly, between 7 to 10 minutes. What was really interesting is 2 patients were on Thrive, and these patients, sorry, this is run out of battery. These patients remained fairly well saturated for quite a long time. So if you look at the timing, it was about 35 to 40 minutes and more than an hour in many patients. I just asked you to think about how long your patients remain saturated if you had not made any interventions. And this was quite fascinating, that they would remain oxygenated for such a long time. So they observed, because it was an observational study, that Thrive gives you time. So it keeps your patient oxygenated so that you can take your time, you can relax and plan your airway maneuvers. In fact, I asked Anil, why did they take so long to jet ventilate or intubate the patients? He said it was such a relaxing environment that we could take our time and secure the airway. So that is what Thrive gives. It gives you the benefit of well-saturated, oxygenated patient. So that was the primary endpoint. I'm a firm believer that every problem has a solution and every threat gives us an opportunity. And I think there is a talk about opportunity tomorrow. And apneic oxygenation is well known. It has been tried about a century ago with nasal cannula. The biggest problem they had was dangerous rise in carbon dioxide. Just going to ask you all, it's nearing lunchtime, so please take a deep breath and try to hold your breath for as long as possible. Let us see how long you can hold your breath. You will see that the rise of carbon dioxide will make you breathe fairly quickly. So this would cause respiratory acidosis, myocardial depression, and ventricular fibrillation in these patients, and that used to be the limiting factor. Can you please check that person next to you started breathing again? We don't want any patients with coma here. Second problem we have with Thrive is airway obstruction. We need to keep the airway open, and let us see what happened in the study. So as predicted, the level of carbon dioxide, so this is the apnea time in minutes in x-axis, and this is the level of carbon dioxide in y-axis. As predicted, the level of carbon dioxide, sorry, can I have another pointer, please? The level of carbon dioxide did go up with time. All right. So I would just request you to look at the number at about 60 minutes. Thank you. Just look at the number. So I apologize, it's in SI units, but please look at how high the carbon dioxide was in the patient who was oxygenated for 60 minutes. So just remember that number, because we'll come back to that in a moment. As predicted, it did go up, but I think the challenge is it to the same level as to the previous studies? So let's just compare that. So in x-axis, we have all the previous studies where apneic oxygenation was used, and in y-axis, you have the rate at which carbon dioxide went up in previous studies. You can see that in almost all the studies, the rate was going at about 0.4 kPa, whereas with Thrive, the rate of rise of carbon dioxide was much lower. So there is some kind of ventilatory exchange happening. We are not sure how carbon dioxide is being eliminated. They think it could be due to dead space flushing. It could be due to better VQ match, but we are not exactly sure how that is happening. So at this point, let's just take a breath and see what Thrive study managed to achieve. So Thrive gives us time to plan our airway management. Patients remain well oxygenated, and it does eliminate. Carbon dioxide is still a problem, but the rate of rise is much slower than previous studies. So let us see how this has gone further. So this is hot off the press, published in BGA this time. For the first time, Thrive has been used as a primary airway device. So from just prolonging apnea time, we have moved on to the next domain where it's being used as an airway device on its own. And I mentioned a problem as a solution. We mentioned airway obstruction as a problem. And these patients were all having laryngotracheal surgery. And in laryngotracheal surgery, having an endotracheal tube is extremely annoying for the surgeon because it comes right in their way. And that is a problem. And the solution they used Thrive as a primary airway device. So what was the problem? They converted it very well into a solution. And they confirmed all the findings which the previous study did. So patients remained well oxygenated for quite prolonged duration of time. The carbon dioxide levels did rise, and the rate of rise was much lower than all the previous studies. The pH rise was also not too bad. So from there, we have moved on to the next step, because we know carbon dioxide rise is a problem. Can we make it any better? And this is a study which came from Australia called as Strive High. From Thrive, we moved on to Strive High. So again, laryngotracheal surgery. They did 30 patient retrospective surgery. So briefly, their anesthetic technique is total intravenous anesthesia. They do topical anesthetic to vocal cords and trachea, so that they don't need to use very high concentration of remifentanil, and they let the patients breathe spontaneously. They used Thrive once again as the primary airway device. Just to point out, the median duration of the surgery was 44 minutes, and some patients remained oxygenated for about 100 minutes. That's fairly remarkable without any airway device or intervention. Do you remember the number I showed in a couple of slides before? Do you remember at about 60-65 minutes, the CO2 was about 14 or 15, and these patients, about 30 patients, they used Thrive with spontaneous ventilation for about 100 minutes. The mean rise of carbon dioxide was almost halved. So one problem is beginning to get addressed. So this is probably only RCT which is being conducted with Thrive. So Dr. Ramesh very eloquently explained this morning why children desaturate much quickly. So I won't ruin this beautiful talk, but they do desaturate. Anyone doing pediatric anesthesia will acknowledge the fact that children desaturate very quickly, and it's fairly common. This study again looked at the apnea time, comparing Thrive versus just jaw thrust maneuver. And you can see the age group in x-axis from 0 to 6 months up to 6 to 10 years, and the time which they remain saturated. So this is without Thrive, and in almost all age groups, you can see the median duration of apneic time is prolonged. And this would be a big advantage for those who are practicing pediatric anesthesia to avoid desaturation. We have had few studies coming from obstetric anesthesia also, and very similar results are being noted. So let's come back to what is the practical use and how it can move on to future. So I'm just going to describe the current users into 3 groups. One is where we can use it for apnea time. Second is where sedation is the predominant way of, and third is can it be used as a primary airway device in future. Every guideline suggests that anticipated difficult airway, we must secure the patient's airway awake. Whereas you come to the ground and you realize it's fairly opposite to what happens. Patients are anesthetized, even by experts, and that's what happens, and that's a different talk in its own. But if the patient can remain oxygenated, it would take away the major morbidity and mortality. The cause of morbidity mortality is hypoxia, not inability to intubate. And Thrive, or high-flow nasal oxygen, would give us that opportunity. It's already becoming a standard of care in the Western world, and it's being used for rapid sequence induction. And we had a talk about extubation. 25% of airway incidents happen during extubation. So if you're expecting a difficult extubation, it would be extremely ideal to have this device. In terms of sedation, awake fiber optic endoscopy and endoscopy. Sedation is done by sedationists for endoscopy especially. We're getting amazing data to see how often desaturation happen in these, and we'll be able to present it hopefully in future. And this is another area we can avoid desaturation in these patients. And already in laryngotracheal surgery, it's becoming the primary airway device of choice. So when there is good, there is always evil, and we need to be mindful of few of the problems which we can encounter with Thrive. It's a good device. It keeps the patients oxygenated, but you still need to have a comprehensive plan for your airway management as it stands today. It will not work once the desaturation has started, so you need to make sure the patient is pre-oxygenated using Thrive. Morbid obesity, they do desaturate. We have seen in all the studies that they do desaturate, but the duration or the time they start to desaturate is much later. One thing I just wanted to point out in this slide is oxygen toxicity. You're using 100% oxygen at 70 liters as it stands. That's We know that oxygen toxicity is a very valid point, and maybe there are few studies already in the pipeline looking at that. In one of the London units, they used diathermy with Thrive, and that caused airway fire, and I would request you to be mindful if you are going to use oxygen with fire. To summarize, Thrive gives you the luxury of time. It gives you time because your patient is well oxygenated. It gives you time to think and plan your airway management. And when your saturation probe is going between 99 to 100, it gives you a nice sense of calmness, so you can think and plan. I mentioned the future airway. Just like Steve Jobs asked his team, do we need these plastic buttons? I'm going to ask you two questions. The first question is, do we need face mask anesthesia in adult anesthesia in today's world? So let's think, what is the role of face mask anesthesia? So one is we use it to pre-oxygenate. There is a lot of studies looking at claustrophobia and face mask pre-oxygenation. We use it to mask ventilate once the patient is anesthetized. So we use two things for that. So one is both our hands are occupied, and second is it is very dependent on the techniques. We need to have adequate seal, and we need to have a good thing. And third is patient is not oxygenated in between during airway maneuvers. So like if you're trying to attempt laryngoscopy, patient is not oxygenated. If you come back and look, will high flow nasal oxygen device take that problem away? It's a nasal cannula, so the problem of claustrophobia does not exist. Definitely, we don't need both hands to look after the airway, and patient is oxygenated in between laryngoscopy attempts. So there is a problem at the moment as it stands, and there is a solution. Is it something viable? Is it something we need to look at? In fact, recent BJA has come up with the second challenge, which is 8 out of our 10 supraglottic devices are not placed in the right position. We claim that we are airway experts, and 80% of the time our device, supraglottic device, is not sitting in the right place. Is this acceptable? Is it time we start looking for something better and something which can work better? So once again, every problem has a solution. Every threat is an opportunity for us to take things further. I see a variety of experienced teachers and very keen postgraduate students in this audience. So, and there was a lot of talk about Research in Leadership Summit yesterday. So I would be extremely keen and really very grateful if we can contribute to this literature. So first, how can we make sure the carbon dioxide elimination is better? And how can we ensure we don't need to do basic airway maneuvers? If we can do this, if this audience can think of ways of doing this, this would be a game changer. And you would be on the photographs there, if we can think about these two. We use, at the moment, you are using 100% FiO2. Is that necessary? Do we need 100%? What is the lowest FiO2 we can get away with? And that is, again, a point of research. If somebody is interested, certainly please look into it. We are still not sure how it works. Interested in basic physiology, that's something to look at. As it stands, this device is quite expensive, and the spare parts almost compare with ProSeal LMA in terms of cost. There are young entrepreneurs here, as I've met few. It's a good opportunity to make the device in India and make it even better, and look at the consumables if we can make it cheaper. I mentioned only few indications, and almost certainly you can look at more options, just like the previous talk, looking at ProSeal for cabbage. So we should start thinking of what are the other new indications we can use Thrive on. So these are some of the opportunities which came to my mind. I'm presenting to the audience. Our friends from ISRO are conquering the outer space, and our friends from Isha today are going to teach us how to conquer our inner mind. I would be very surprised if our audience from here would not be able to conquer these opportunities. Jai Hind, thank you very much.